So next I'd like to invite Dr. George. Dr. George is from the Aravind Eye Hospitals and he will be talking to us about an approach to management and diagnosis in pachychoroid spectrum. Thank you, George.
Yeah, thank you for having me here and this opportunity. So let's look at an algorithmic approach to pachychoroid disease spectrum. Can we have the slides? So basically, we have a group of diseases with common imaging findings, especially the choroidal imaging findings in this group of diseases. So now it's an ever expanding spectrum of disease with newer additions happening almost every year. So the usual entities are pachyepitheliopathy, CSC, pachyneovasculopathy, polypoidal choroidal vasculopathy, focal choroidal excavation, and peripapillary pachychoroid syndrome. And very recently, pachyvitelliform maculopathy also has been added to the spectrum. So common to these diseases are reduced fundus tessellation and increased choroidal thickness, no consensus, but generally more than 400 microns thickness, either a diffuse thickening like this or a focal thickening. And more importantly, dilated hallux vessels, more than 80% of the thickness with overlying choriocapillary attenuation or compression. And early phase of ICG showing delayed choroidal arterial filling. And you have the dilated choroidal vessels, and in the mid phase, patchy areas of choroidal vascular hyperpermeability in patches. So these findings, imaging findings, are common to these diseases. So the first entity is epitheliopathy, which is nothing but non-specific RP changes with or without pigment epithelial detachment, a prototype case where RP changes overlying a area of choroidal vascular hyperpermeability on ICG, and a pachychoroid with dilated outer choroidal vessels. So in this entity, you can have these called pachydrusen, which are more than 125 microns in size, and either they are singly or in pairs distributed all across the posterior pole, not like in a dry AMD where there is a thin choroid and there is a confluent drusen which is accumulated at the fovea. And here we have a thick choroid again overlying. Pachyvitelliform maculopathy is a distinct novel entity where you have no fluid again like PPE, but you have this vitelliform material accumulated, and should be aware of this entity because over the 5-year or 6-year you can say that it proceeds to something called pachygeographic atrophy. So moving to the next entity, that is CSCA, we all know that young patients, type A personality, acute serous macular detachment overlying a pachychoroid. There are variants like this when you have a fibrinous variant or an exudative bullous variant associated with exudative RD, or with PEDs and hyperreflective fibrinous material on OCT. Whereas in chronic CSC, we look at diffuse RP epitheliopathy, multifocal leakage, and diffuse ooze in the late phase of fluorescein angiography, OCT. You see these findings of intraretinal fluid. You have photoreceptor outer segment elongation associated with PEDs, and later on goes in for foveal thinning and atrophy. So as we were mentioning that Swepsore's OCT showed it could be a diffuse thickening or it could be a focal choroidal thickening, especially nasally or temporally. The best example in this scenario is peripapillary pachy syndrome, which I believe is again a variant of CSC which happens in elderly and bilateral. So you have a nasal macular preferentially thickened choroid and nasal macular intraretinal and subretinal fluid. For example, in this case, you can see on either side of the peripapillary intraretinal fluid, subretinal fluid, and this hypertransmission defect in the overlying the choroid on the peripapillary area. and the autofluorescence showing the peripapillary RP atrophic changes or mottling and peripapillary pachyvessels, and preferentially choroidal vascular hyperpermeability on the peripapillary choroids. So now with these variants, now what indications of management usually observe in acute case for 3 months, and if it recurs with visual defects or other eye has permanent visual deficits or chronicity signs which we saw on FFA, IC or OCT, then you need to treat, or if there is a patient need occupational or other need for early restoration of vision. So the commonest modality all of us know that is focal laser to the early FA point leaks outside the fovea, give very gentle grade 1 to 2 just visible burns, 2 to 3 burns to basically stop the RP leakage and minimal scarring in that area. So but when it happens in the subfoveal area or juxtafoveal area, you can't treat these cases with the conventional laser, because conventional laser has the problem with overlying neurosensory retina, that is a collateral damage. So that doesn't happen. So these short pulses of these laser to stimulate the RP. So that is what is being done in subthreshold micropulse laser and heat shock proteins, and then this fluid resolves in the micropulse laser. So various studies have shown efficacy. The current issue is a lack of a uniform treatment parameters, but it's recommended that it should be titrated based on an extramacular burn, and it should be sequential follow-up. So we are working on that, and soon probably we'll have a uniform parameter. So coming to the next modality, especially for chronic CSC, the gold standard is PDT, which causes a short-term choriocapillary hypoperfusion, but on a long term, in 90% or more of patients who have causing a long-term vascular remodeling and thereby decreasing the choroidal vascular hyperpermeability and no more recurrences. So half dose or half fluence are equally good and better than standard fluence PDT, and the Indian results are also 90%, which is comparable to the Western literature in such cases where you have chronic CSC and you have these kind of subfoveal PED and fluid, and fluorescein ICG showing a diffuse leak and leaking PEDs. So in this scenario, you cannot do any other treatments, injections don't work, so we have to go for PDT. So this is like the PED and the fluid disappearing after 1 month and after 3 months of half dose PDT in this patient. So there are some OCT biomarkers which determine the outcome. So one worse outcome is expected in when you have these large cystoid space, something called CMD or cystoid macular degeneration. This is a poor biomarker, again acquired vitelliform lesions. You see this hyperreflective acquired vitelliform lesions in the subretinal overlaying the PED. Here you can see that's a poor biomarker, and you have after treatment there is no response even after a half fluence PDT. So next entity is pachyneovasculopathy. This is nothing but a type 1 neovascularization on FA and ICG overlying a pachychoroid, and you see the PED, flat irregular PED. For example, this patient was referred as chronic CSR, this flat irregular PED, and then overlying, mostly it overlies a pachyvessel. So here the octa is very useful, superficial plexus normal, deep plexus normal. When you come to the avascular retina, you find this filamentous tangle network, and this octa is, this overlies the flat irregular PED on the fundus, and octa is very sensitive in picking up this network, because the fluorescein and ICG angiography can miss this subtle neovascularization in the setting of a pachyneovasculopathy. So the last entity, PCV, is a serosanguinous maculopathy called as aneurysmal type 1 neovascularization. So still ICG is the gold standard in picking up, where you have these hypercyanosin nodular lesions, but now we are moving to non-invasive imaging, wherein 3 major criteria Asia Pacific guidelines, like sharp peaked PEDs and sub-RP ring-like structure and on-fast OCT showing this complex RP elevation, have almost 80 to 85% sensitivity in picking up compared to ICG angiography. And in the recent recommendation, the on-fast OCT complex RP elevation has been replaced by color fundus photograph showing orange subretinal nodule. So, because many clinics lacks PDT and ICG in treating PCV, so basically based on OCT Octa based criteria, monthly injections of one of the newer anti-VEGF agents work better for PCV based on the Planet study recommendation. Go ahead with anti-VEGF monotherapy after 3 loading doses. If there is persistent fluid, then go for ICG and consider PDT rescue. But with extended loading doses up to 6 months and treat and extend regime, even without PDT, there is a good polyp closure rates even with any of the newer anti-VEGF, including faricimab, brolucimab, or aflibercept, or any of this. So focal choroidal excavation can also be part of the pachychoroid, where it's a sharp choroidal excavation on SD-OCT. It can be conforming or non-conforming if the neurosensor retina is detached from the RPE, but treatment is not required unless you see this subretinal hemorrhage, which can be associated with CNV or PCV. And the good thing is that only fewer injections of anti-VEGF are required in this scenario to take care of the CNVM or PCV in this scenario with FC or focal choroidal excavation. So the algorithmic approach would be, if you see a PPE or PVM, that is epitheliopathy or a vitelliform maculopathy, observation is sufficient. PPE should be kept in mind that it can proceed to CSC, and pachyvitelliform maculopathy can proceed to pachygeographic atrophy. So these patients should be aware and should be on a periodic follow-up. CSC is a choroidal disease now with swept source OCT and ICG showing features, and acute CSC is observation and focal laser for extrafoveal leak if it persists, and micropulse laser for subfoveal and juxtafoveal leaks. The criteria is yet to be defined with a uniform parameter, but chronic CSC and peripapillary pachychoroid syndrome, half dose, half fluence PDT is the gold standard currently, and pachyneovasculopathy and FC associated CNVM. Octa is very important and sensitive and specific to pick up. Anti-VEGF therapy, only few injections are sufficient, and PCV is now moving to non-invasive imaging, and newer anti-VEGF monotherapy is the first line, and if persistent polypoidal lesion, go for ICG and combine PDT as a rescue therapy. So thank you for your kind attention.
Thank you, Dr. George. That was a very extensive coverage of the thing with a good algorithmic approach at the end. We'll take questions after a few